I'm Dr. Mark Goldstein, Hematology Oncology. I'm in Maryland with the Center for Cancer and Blood Disorders, and I have the privilege of welcoming Dr. Christian Rolfo, who previously was at University of Maryland and now at Mount Sinai, giving our talk tonight on lung cancer screening. And he is a professor of medicine and hematology oncology at the Tisch Cancer Institute, and has a focus on drug development and has specialized in thoracic malignancies, biomarkers, and has held appointments in other institutions, including in Argentina and Belgium and Italy. He could probably fill us in with more of the specifics of that, but he was also a PhD and MBA in his training in Italy and Spain, respectively, and completed his training in Milan. And I've learned that he is the president of the International Society of Liquid Biopsy and chair of Education Committee at the International Association for the Study of Lung Cancer, IASLC, and a member of the Drug Approval and First in Human Commission in the Ministry of Health in Belgium when he was there. And so we welcome him to this talk, and I appreciate the sponsorship from the Maryland DC Society of Clinical Oncology and the Oncology Foundation for helping put this together. And now I'd like to turn it over to Dr. Rolfo.
Thank you. Thank you very much, Dr. Goldstein, and thank you for the Society of Medical Oncology in Maryland and DC. It's a pleasure to be here, and we will discuss about an important topic today, that is screening of lung cancer or early detection as well. So I will share my screen. Give me 1 second. I hope that you see my slides. Perfect. So we will have some questions at the end. I prefer to have the questions at the end, and the only thing that I will ask, if you can mute your microphones in order that we have a smooth lecture. And I'm very happy to be here to discuss that. You will see that at the end of this lecture, you will have some knowledge about the idea is to have some knowledge about the screening, why it's important screening patients and populations, and also why it's important to use liquid biopsy. What is the future of liquid biopsy in the screening specifically, because it's something that we are applying already a lot in metastatic setting, but we will be moving forward to early detection. So that's are my disclosures. This is the typical flyer that we see in several institutions: lung cancer screening, which kind of patients are eligible, and that's are the rules: 50 and 80 years old, if you're currently a smoker or you have quit in the past 15 years, if the number of pack of cigarettes are smoking per day and number of years that you smoke is calculated around 20 pack per year or greater in history of smoking. So that's are the general invitations or general requirements to be invited to participate in these screening programs. We are not taking in consideration here a big number of the population that are the non-smokers, and we can discuss about that in the session of questions. But I will focus specifically in this screening part in general population that is amenable to go to screening. Several studies, and this is one of the studies that I think is very interesting to cite. This historical study in 2006, the group of my colleagues that Dr. Jankelevich and Claudia Henschke published this article in New England Journal of Medicine, talking about the benefit of stage 1 in lung cancer screening with low-dose CT scan. And this is the first, I would say, article that was really showing that the low-dose CT scan screening can detect lung cancer that can be curable. And that is very important. If we see the ELCAP, that this is the name of this consortium, after 10 years in resected patients with stage 1, the survival is around 92%, compared with all the cancers, that is 80% in stage 1. So this is a very, very interesting, in all the cancers, I mean in all the cancers, lung cancers. This is a very magnificent opportunity to cure patients in stage 1 when we are screening these patients and identifying in time. That's are the randomized trials that you can read, and this is a very nice review article that I suggest to read. You will see some of the images because I consider that this is a very comprehensive overview. This was published in Nature Review of Clinical Oncology in 2021. And as I say, here you have the randomized controlled trials of low-dose CT scan screening to lung cancer screening. And all the trials that you see, the major trials, the NSLT and the Nelson, that include a big number of patients, 53,000, 15,000. And then you have the underpowered studies that are not even very underpowered, because we have a big number of populations here, between 4,000 patients and 2,700 patients. But you see that the most important one here, the first one, that is the low-dose CT scan screening versus X-ray, was also demonstrating, or was giving an idea, starting in the thousands, giving an idea that we need to use low-dose CT scan screening compared with X-ray for screening the patients. And the Nelson studies that was not having, was the low-dose CT scan screening versus not intervention, also demonstrate that reduce the lung cancer-related mortality in a very important manner. So if we are looking for these studies, specifically in stage 1, all these studies demonstrate an important, have an important number of patients in the trials, between 50 and 80% in stage 1. The detection rate was similar in the trials. Some of them, like the mild, that is the Italian study, was a little bit higher. But the outcomes in mortality and survival and reduction of mortality and survival are very important in all the trials. If we are looking for the trial that I was mentioned before, the CT scan, low-dose CT scan versus X-ray in the NLST trial, show a 20% reduction in 6 years cumulative mortality rates. So it's more important to do, and it's very important to do low-dose CT scan screening than X-rays, and that was one of the marks of this trial. Was able to accomplish and change the paradigm how we are screening the patients. And there you have the numbers for the stage 1, stage 2, 3, and 4 in the different scenarios. It was very similar. So as you see here, in the part of the low-dose CT scan screening, majority of the patients were in stage 1, compared with the contrary way in the X-ray. So, but that was some of the difference that we saw in the study. Another part of this screening, and also shown by this group, this consortium, the ELCAP, was the non-solid nodules. And compared with the baseline low-dose CT scan and annual low-dose CT scan screening, all the patients with stage 1 adenocarcinoma have a median time to treatment that was 19 months and a survival of 100%. When we are doing that means that when we are doing in time the diagnosis and the surgery in these patients, we have an important opportunity to gain survival in this population. And there are some recommendations that are coming from this follow-up, and the risk category is important. So we have an intermediate or high risk for lung cancer, a high risk of lung cancer, and a very high risk of lung cancer that you have there, the characteristics. I will not enter here, but it's important to see that these kind of recommendations can give us the idea how is the periodicity that we need to use for the CT scan in these patients, coming from the every 24 months to a short follow-up terms as a referral to the multidisciplinary team for follow-up and workup, in this case, to see if it's positive for lung cancer or not. One of the questions that we have when we are talking about screening, if it's cost-effective or not, and was demonstrated in different studies that is cost-effective when we are comparing with the QALY, for example, that is one of the markers for the quality adjusted life in years. or even the life year gains, that is the LYG, that is also was also this study performed in other countries like Canada, United Kingdom, and Switzerland. Unfortunately, there is not in all the places national screening programs, and it's something that we need to advocate. In the United States, we don't have a national screening program. There are some screening in some sites, but it's not still something that is applicable in all the centers and in all the states. So it's something that we need to certainly work on to have this cover and be able to be accessible for everyone. And this is the timeline from the 70s when we started to talk about this cancer screening until 2020 to 25, that we are not only implementing the part of the CT scan, but also we are including research on that. And also, for example, integrating other programs like smoking cessation, integrating also biomarkers, for example, in blood that we will discuss today, and other technologies like radiomics to try to improve the rates of detection in lung cancer. There is one of the programs that is called Spiral, that is the screening, planning, and implementation rationale for lung cancer. And it's taking in consideration all these, the population, the recruitment, the nodal management, the screening frequency, the sex differences, the cost effectiveness, and also the research implementation programs or projects that we can include in these programs. So in our institution in Mount Sinai, our colleague, Dr. Javier Zulueta, is leading this program that is also for using artificial intelligence for a lung nodal tracking program. So we are tracking patients that have incidental nodules. That's another way also to see screening in patients. So trying to identify these patients that have incidental nodules and follow up these patients very shortly in case that they have some characteristics that we need to follow up. So what are the problems that we have in lung cancer screening? It's a poor implementations, 3 to 14 of the eligible patients in the United States, 22% appropriate annual follow-up, poor smoking histories, so that's important. We are not documenting that very properly. Up to 50% of the lung cancer patients are not eligible for lung cancer screening. And also we have important inequities like racial, demographic, and economic factors that are represent a challenge in the lung cancer screening implementation. And finally, one of the most important challenges that we have in the last 2 years was the impact of the COVID-19 pandemic in the lung cancer screening, when we have resulting in a significant decrease of these screening programs. The people was afraid to go to the hospitals for screening, or several of the screening programs were even canceled or diminished for the number of staff that was impacting by this COVID pandemic. So moving to the last part of the spiral that you saw in the image, I would like to follow this with the biomarker implementation. And here I would like to open the door of the liquid biopsy. We know that liquid biopsy we are using from several years already, and it's a very high concordance in tissue, specifically in the area of the advanced disease. But we were moving right now, after the use of detection of some mutations, detection of mechanism of resistance, monitoring of the response, we are moving to minimal residual disease and early detection. The last frontier will be the cancer interception. That is the possibility to capture the biomarkers that are in circulation before that the tumor is visible by images. But we will focus in early detection, and the idea is to try to increase the detection of these patients. And we can do here different approach coming from the ctDNA, and I will focus in this part specifically in the methylation, microRNAs, proteomics, metabolomics. We have actually now also glycosaminoglycans. We are using also other sites or other analytes of ctDNA, of liquid biopsy, like CTCs, exosomes, and so on. So it's very, very variable, the opportunities that we have here. But the most important thing is that we need some of the liquid biopsy technologies that is complementing low-dose CT scan screening, but also being in itself a biomarker opportunity to detect these patients in areas, geographical areas, that we don't have any low-dose CT scan screening program. So having a technology that is able to detect these patients a priori, that will be a very interesting opportunity. We have two different approaches, tumor-informed in some of the nodules that we have, and this is more applicable for technologies that are more used in minimal residual disease. But also we have the tumor-uninformed approach, so when we don't have any tissue and we depart from liquid biopsy. And in this case, I will focus in methylation. That is one of the technologies that is commercially available. It's not still FDA approved. And this technology have the advantage to also to cover or to filter the clonal hematopoiesis, as the same is happening with other kind of approach like a plasma and leukocyte ctDNA analysis. There are two different approaches in multi-cancer detection tests that are using a test for different tumors or single tumor detection test. And using also methylation, I will show you some examples. But here we have a lot of concerns of questions. Is the same specificity and sensitivity in all the tumors? There is an intrapatient variability in the same tumor type that is already known. And also, is this one fit for all approach the correct way to go? It's true that when we are doing multi-cancer detection tests, we are able to distinguish patients that are, for example, not having a screening program. If we are talking about sarcomas or other kind of tumors that they don't have any screening programs in place, having multi-cancer detection tests could be possible. One of the examples is a woman that is a smoker, and we are covering with a low dose, so she will need to be included in low dose CT scan screening, screening for breast cancer, screening for ovarian and endometrial cancer. So there are several opportunities that need to be included. So having this liquid biopsy could be an opportunity to avoid several images for these patients. And that is the idea behind of this multi-cancer detection test. When they developed this technology, and the company that is commercially available, they were looking for different biomarkers, mutations, chromosome alterations, and methylation patterns. So they finally decided the methylation patterns in this publication was the most sensitive. That was in the discovery and then in the validation. And finally, the final validation that I call this the Ariana treat, because this was like a kind of selection to arrive to the center of the problem. They decided that as I say, methylation was the best option. If you are looking for any methods in liquid biopsy, we need to have a very high specificity. So always when you read a publication or you see a publication in early detection, look for high specificity, and then we can discuss about the sensitivity, because that means when we have a high specificity that the truly positives or the positive are truly positive and the negatives are truly negative. So this technology in the beginning was starting with 19% of specificity, so a very high. And in the final validation, the specificity was 99.5, so very, very high, with an specificity of 51.5% for cancer detection. But take in consideration here that there is a very big variability. This was a multi-cancer detection test. So we have here different approach, different sensitivity. For example, prostate cancer from 420 patients, 47 patients were able to be detected, so 2%, compare, for example, with liver cancer or liver duct cancers that we have a 93.5% of specificity. In the case of lung cancer, the specificity, the total specificity was 74.8%, but take in consideration that in this study, they include cancer and non-cancer, and stage 1 to stage 4. So we have a big population of patients with stage 2, 3, and 4, and only 30% of the patients were stage 1. If we are looking specifically for some of the tumors, in the case of the lung cancer, 21% stage 1 was sensitive, the sensitivity was for 21.8%, compared with other tumors, like, for example, head and neck, that was very high, more than 60%. And also when we are doing these kind of selections between stage 3, that was 77%, stage, for example, 1 to 3, that was 40%, but the real situation in stage 1, the sensitivity was 16.8%. So we are not still in the sensitivity that we want to be. We are in a very high specificity, and that's a very good thing, but we are not still in the very high specificity, sensitivity. If we are talking specifically for some subtypes in different tumors, I told you that lung cancer was 21%, and that is not in the publication, but if we are looking in some abstract presented in Congress, we see, for example, that there is a diversity between adenocarcinoma and squamous cells in stage 1 and stage 2 sensitivity. And the same is happened with other tumors, for example, in breast cancer, with hormonal receptor positive and hormonal receptor negative, there is a very variable differences in these tumor types, in subtypes of the same tumor. The last study that was presented in ESMO last year is this study, is the Pathfinder. And here we have a little bit more, so we do a step further in the application of this technology, including also patients that are in screening programs. So in this study that was conducted in 7 sites in US and 200, more than 6,000 patients included. In this study, you see that there was what they call detectable cancer signal detect was in 92%, so was around the 1.4% of all the patients. And what they found here is that in this population, in some solid tumors and hematological tumors, these patients were able to be detected, 24 in a high-risk cohort, 11 in a non-high-risk cohort. 7 of these patients have recurrent cancer, 14 were only in an early cancer stage, and 26 cancer lacking standard screening. So we are including here some patients that were not able to get or to be detected by the screening programs because they don't have a standard screening program. But I want you to focus your eyes in the 3 angles of this image. So the 3 angles are representing the stage 1, and specifically in the solid tumors area, you see that the stage 1 is very minimal, 1 in the liver, 1 in uterus, and 1 in ovary. So we don't have a lot of stage 1 in these figures, and that is something that is still missing in this opportunity to select these patients in early stage. Another advantage of this technology is to detect the cancer origin. And that is important when we have these patients that have a still primary unknown and possibility, or we don't see the primary, the possibility with this liquid biopsy methylation to detect the cancer origin was very high. So in conclusion, for this specific technology, we have a very high specificity, but a very still low sensitivity for early stage. And this is very important because we need to have an increase on this sensitivity to be applicable in the large scale population. Otherwise, we will have patients that are false positive or false negative, that we need to do a lot of images and follow up and stress the patient for sometimes not get any results. So I think we need to be a little bit more responsible when we apply this kind of technology, and that is something that is a call of action for my colleagues to try to apply this when we have a higher sensitivity and not specificity alone. That's are the cancer identified within 1 year with this multi-cancer detection test. And you see that there is also an increase compared with the patients who have a screening detection and only compared with the others that have a clinical detection. Obviously, this is an advantage, but as I say, we are not still in the range to be applicable this in the large scale populations. Going to the same principle, so methylation, but for a single detection test, this study that was presented in World Lung Cancer Conference 2 years ago is a combination or is an example how we can combine low-dose CT scan screening and radiomics specifically for this. Radiomics is the opportunity that we have looking for the images to detect some features that can be linked with aggressiveness or even in this case, possibility to be detected as cancer, and the conjunction or the combination with methylation. So this Pulmosec approach, that is the name that the researchers gave, that was conducted in China, this is able to detect some of the populations with nodules that are very, very minimal, and that is an advantage. Obviously, sensitivity is not so high when the tumors are very minimal in size, but it's really interesting to see that we can start to open the door for this kind of technology as well, and combination of the improvement of the technology in images, that is the radiomics and the liquid biopsy. There is another part of the liquid biopsy that is called fragmentomics, and is the fragments of the DNA, and we are taking in consideration the size of these fragments. So in the study that I showed before, they were also studying fragmentomics, and they have there a sensitivity that was not very high, but you need to consider that fragmentomics is very variable in definitions. So in this new study that is called Delphi, or Delphi, is a technology that is using fragmentomics. They have 2 studies conducted at the moment, at that moment, when the moment of that was this, the technology was known, that the Lucas approach, this is the validation study, and they have a high specificity, 80. It's not higher like the other one, like I show you, 99.5. So sensitivity here will be lower. If we calculate a high specificity, the sensitivity will be going down. But what is important here in this study, that they also include patients with a high-risk population, so patients with nodules. This technology is now in new evaluation, and there are new publications that will come in. There are studies ongoing, and seems that they have a better specificity, and that will increase, obviously, the possibility to get a better sensitivity when the technology is improved. So we will hear more about that. The concept of liquid biopsy is not only applicable in the screening of lung cancer, and you saw that we have multi-cancer detection tests, and I show one example of single detection test, but this is another example in another tumor that is orphan for screening programs, and that is the hepatocellular carcinoma. And nowadays we have some opportunities. That was a commentary that we did from this Delphi approach as well in this month in cancer discovery, and the opportunity that with this genomic analysis of the fragments, so this fragmentomics, we are able to distinguish hepatocellular carcinoma from non-hepatocellular carcinoma, and that is something that is really important and will have an important implications in survival of these patients. That is a very, unfortunately, very lethal situation as well. Other approach that we have in liquid biopsy, and you will hear in the future, is perhaps this kind of approach that was also presented by the group of Stanford, Maximilian Ding, and we have this commentary in Cancer Research, that is the use of the bronchoalveolar lavage as a source of a screening program. So that could be something that we will hear in the future. Subject undergoing to bronchoscopy for suspected nodules, for example, or undergoing to bronchoscopy for non-oncological indications that we can have some incidental nodules there. Using together with the CT scan or low-dose CT scan could be and a possibility. And this technology in cases of advanced disease was showing to be very high concordance with tumors, with blood, and actually even better in some cases for detection of alterations in advanced disease. Going to another scenario, I show you before the MILE study, that this is the Italian study. There is a BioMILE study that is the part of the biological component of this study of the images of low-dose CT scan. And they include in this, we will say, multi-omics approach, the low-dose CT scan and the microRNAs in the blood. So they were looking for microRNA profiling that are coming from specific cancer cells or detected specifically for lung cancer, specifically in the profile. And they include here more than 4,000 patients with cancer diagnosis less than 5 years ago, exclusion criteria, lung nodules under surveillance, or even CT scan examination less than 1 year ago that were the exclusion criteria. They include normally patients for screening programs and not recruiting people that was not following the inclusion criteria. So they divide three categories. The first category was the patients who have the two negatives, so low-dose CT scan screening, very minimal alterations and low microRNA, or one positive, or the two positives in patients who have high risk of develop lung cancer. And according to that, they did also low-dose CT scan interval in 3 years, 1 year and 3 and 6 months for the high-risk population. What they found is the risk outcome was 5% of the population was in this specific two positive, compared with the 58 that were negative, two negatives. And if we are looking for the incidence of lung cancer, the higher incidence was obviously falling in this category of the two positive, microRNAs positive and low-dose CT scan screening positive. And you see there was 36.64% compared with 1% in the two negatives. Also, mortality was very high in this, the incidence of mortality was very high in hazard ratio compared with the two negatives, 32.24 versus 1% of hazard ratio. So important this kind of technology in detect mortality. And I have, and also in a category of 255 patients, 225 patients that they have subsolid nodules. The lung cancer from subsolid nodules was 3%, and there were not deaths associated to this in this kind of population. So very important to conclude that these microRNAs, this is another example of using microRNAs in combination with low-dose CT scan screening. There is also new areas that we are exploring right now, that is metabolomics. And this is an example that we was doing with a group in Canada, using 5 metabolites. We was able to distinguish between stage 1, stage 2, and 3, and healthy controls. There are some studies that are coming at the moment for that, and you will hear, if you're going to ASCO, there will be some presentations in ACR as well. And the last frontier that was published last year in December 2022 is this non-invasive for any stage, also using this multi-cancer detection for approach for glycosamine glycans. So this is a very interesting study, an approach for using plasma, urine, and the combination of both. And you see that in the case of lung cancer, that is here, the combination and the urine seems to be a very high incidence in sensitivity for this population. So this is a very preliminary approach. We just started to hear about that, but for sure will be something interesting for patients who have specifically ctDNA non-sheeting ctDNA in the blood. So that is something that we need to consider in the future. So what we are doing in our institution as a project, we are working in beyond the ctDNA, working in CTCs, metabolomics, and also using extracellular vesicles to try to identify this patient in this multi-omics approach. And this is the people who is collaborating in this specific approach of multi-cancer detection tests and lung cancer, but we will also use some other tumors as well to see if this approach is increasing the sensitivity that we need. So my take-home message for today is that early detection is a crucial point to increase the survival rates in cancer. The liquid biopsy is an ideal tool for making it possible. So we need methods that are complementing the screening programs as low-dose CT scan screening, but also, as I say in the beginning, methods that are standing by themselves. And also the idea to go for multi-cancer detection is true that we are maybe using this specific approach for areas or populations that we don't have a standard screening program, but also the single detection test will be very accurate and increasing the sensitivity in some tumors. So it's not clear yet which one is the best approach. Important to include also high-risk populations in all these kind of trials. And we are not in the best scenario that we can be, but we are not so far to get it. So with that, I conclude and I invite you for this annual meeting that we have in our Society of Liquid Biopsy that this year will be in Madrid on 19 and 21 of November. And I hope that you can join us. Thank you very much for your time.
That was
Answer
excellent.
question.
Thank you, Dr. Rolfo. We're going to open this up to questions now. If you have any questions, you could present to Dr. Rolfo. You could either just ask them or put them in the chat.
Maybe I have a question for you guys that is easier in the contrary way. So
You're testing us?
are you using, in some cases, this kind of technology of liquid biopsy? Because I was recently in a conference of early detection in Miami, and I asked that which kind of approach are you using? And several doctors, general oncologists that were in the room, they raised their hand and they said that they are using this methylation approach. And I want to know your opinion about that.
Well, if I may, I can say that I recently learned about the gallery and met with them to learn more about it. And it seemed pretty interesting because they can screen for 50 different cancers and even tell you to some degree where they think it came from. I have never ordered the test, but I've talked to a few patients about it. They seem interested. The only problem is, even though it's been out for a couple of years, it's about $900, and it only tells you in that moment of time. It does, so you'd have to do it once a year, unless at some point it becomes covered. I don't know if that's more cost effective, relative to, let's say, a CT chest. I'm not sure what the real actual sticker price of that is, but I don't think it's quite that expensive. But you do cover more territory with this methylation test.
Yeah, it's true. My only concern there, and it's also a very good tool if, for example, in one population that we was not discussing here, that is the non-smokers. So patients that never smoke, that they can also have risk. We don't need to forget that 20% of our patients in lung cancer are never smoker. So that they have maybe secondhand smokers, or they are in contact with radon or with asbestos. So there are several other options, that possibilities that we can have. So this kind of tool will be very useful, but I think we are not still in the highest sensitivity that we need to be applicable in all the. I have the same impression. I don't know, when you have this kind of cases several years ago, that some colleague was asking for a CAA or not a PCA, but a normal other biomarkers, and there are not images available possible to detect any cancer, and you start to follow up the patient without any benefit because this was a biomarker that was very unspecific. This is not the case here because we have some that is very specific, but the sensitivity is not so high. So I think will be a problem to get that. And also it's true that several liquid biopsy companies are going through the Medicare approval that is easier before to go to the FDA. So they are in the market and then they go for the FDA approval. And that is something that we need to be very careful what we are using in the patients. No?
There's a question in the chat.
Yeah.
Dr. Rolfo, what method are you using to collect CTCs?
Yeah, so the here we in the images that I show there in this project, we are working with a company that is called Lung Life, that they were using they are using antibodies, so for the isolation, and this is one of the technology we are using. Also, we just got an award from the National Cancer Research Foundation for use a new technology that is called TelBio, that is also using antibodies and a kind of filter. So there are some technologies that are more accurate than others, and that's the idea. But it's not a standard, so that's one of the problems also of the CTCs.
You had mentioned in your presentation that there were, on one of your slides, that there were 50% of the population that were ineligible for screening. Can you tell me what that means? Why those individuals were ineligible?
Because maybe there are patients that are younger than 50 and they are heavy smokers, and we are not taking in consideration these patients. One of the problems that we have also in the United States was the vaping, and we are not taking in consideration also that population. We are not taking in consideration patients that are, for example, with other tumor types that they also can have some risk factors, but they are treated in other tumor types, or they have a prostate cancer, for example, and these patients are not eligible for this kind of screening. And also there are a lot of inequities, as I say. This is a very important point, that rural areas, for example, we are not talking only about racial or underserved population, but rural areas, for example, that they don't have access to these programs. There are some countries, for example, in Brazil, that they are using right now a pilot project that is going with a truck near to some populations that they have high incidence of smoking, and they can collect the people there. So these kind of initiatives to try to bring to the people the screening is something that is very important. There are some programs, for example, we just opened in Egypt, that is the first country in the MENA region and in the North Africa that have a very high incidence of tobacco. They are starting to smoke in the media of 12, 13 years old. And they start the screening program. So they were able to screening in the first month 1,500 patients. So it's unbelievable the need that we have in different regions in the world of these programs.
Can you comment on one of the other platforms which I've found that it's a 4 biomarker panel, and the study was looking at that with a different criteria, the PLCO 2012. There's like a combination with that. What I've got here is on the biomarkers was surfactant protein B, CA125, CEA, and cytokeratin 19. So they use those 4 plus the scan,
yes,
and had better data on detection, let's just put it that way, than CT alone. And also just comment on the realities that we're facing with CT. I mean, it's clear we've had screening, I guess, since 2013. Medicare has been on board since 2015, and yet 5% at best on average CTs are being done for eligible patients. I mean, maybe it is that biomarkers are the way to go. We just can't get people to the scanners.
Absolutely. That's a big thing. Also, you have patients that perhaps are going to the first screening, to the first CT scan, and then they move, they go to other place. There is not a continuity in the screening, or the people became tired also to go one time per year. They don't see the real utility sometimes. So it's very important that we encourage the people, and we have a lot of education why it's important. And the education needs to start in the schools. It's not, we don't need to go to the smoker right now. We need to go to the non-smokers to try to prevent the smoking there, and try to encourage that there is screening need to be part of the routine when you are in this kind of situation. But also, I would love to see in the future a screening for non-smokers, because I think that is something that we need to invest a lot in this kind of populations, that especially in some areas, second-hand smokers, or you cannot imagine in rural areas, for example, in Latin America, that they are smoking for the heating of the house or the cooking, that they are using still good for cooking. So it's really important that we see all these kind of situations when we are trying to save people from lung cancer. And the example that you nominate about this kind of biomarker is one of the other examples that we have. No, there are several attempts to try to identify biomarkers, but I think this is the way to go. We established that the low dose CT scan is the correct way. We need to improve now this, and the way is research is the only way.
Well, do you think that at this point that the general practitioners, I mean, I basically see an internist for my care, but I haven't been asked anything about screening. I was a former smoker a long time ago, so and which is in my record, my medical record, but I haven't been asked, or there hasn't been any information out there about the possibility that maybe I might need to be screened. And I'm looking obviously more carefully now that I'm becoming educated about it through this program. Do you see that being used more?
Yeah, that's a very good point. Actually, some of the programs, for example, medical records like EPIC, is having these pop-ups that are helping us to identify these patients. And actually, there are some programs, that are some institutions that are including in this pop-up also the smoking cessation. So the documentation of the tobacco history is very important. It's something that we are not really paying attention sometimes when we are discussing with the patients, because there is a tendency also in the patients to minimize the number of package that they were smoking. So it's important that we ask also to the patients, and we say, try to be honest. And it's surprising that sometimes you are speaking with the patient, and in the same room you have the family, and the family is saying completely another number. So it's very important to collect that and use the technology to identify these patients. And artificial intelligence, using also the possibility to identify patients like you say, with a high history of smoking or incidental nodules, that will be, I think, the future to identify these patients as well. And smoking cessation programs need to be a complementary approach for this low-dose CT scan screening.
Can you comment on the radiation dose itself? So there's been questions from patients that I've fielded, the difference between the radiation from, in, let's say, millisievert or whatever for mammogram versus this. And if you're going to do it year after year after year, at least up until a cancer is found, but let's say someone did it for 15 years. I mean, do you ever pause a little bit with that thought that you're exposing the patient to radiation, even though it's a low dose, it's still more than patients normally would get?
That's a very good point. I don't have a right answer for that, but I will say that the benefit override the risk. No, so it's in patients that they have, for example, in this case, high risk of lung cancer. I don't believe that the screening of lung cancer is representing any harm for them, to be honest, compared with the benefit that we can get if we are able to distinguish these patients in time. But it's obviously there are some studies on this regard for sure.
How can you better educate the 10, 20, 30 pack year smokers to get a low dose CT? Do they really care about quitting or improving their health? I mean, the percentage is so low, and it's tough to get people to smoke. Do they really care about being educated?
That's a very good question, and I think it's very difficult to answer in a general population. But I will say that several patients, they are trying to reduce the number because they know the risk, and there are, and that for the reason I say smoking cessation programs are crucial here, because we are not talking only about the pills that they can get, but also a psychological support that they also can understand what is the risk, but it's very difficult for patients that are very high addicted to the tobacco, because it's an addiction, so it's impossible in some cases. But several people, and actually were a study also genetic predisposition to tobacco as well. So there are several studies that were trying to explain this kind of addiction beyond the nicotine that is obviously. But yeah, it's very difficult. It's very difficult for that patients. Some of the patients, when we diagnose lung cancer, they immediately stop. But that is, and it's not late, because if these patients have a lung cancer diagnosis and they stop, we can still even recuperate capacity, pulmonary capacity in some case, or improve at least the pulmonary capacity in some ways. But also in terms of the treatments that they need to receive, they can be responding even in a different way if they stop smoking.